Hello, this is Dr. Alan Lumsden. I'm the Medical Director of the Houston Methodist DeBakey Heart and Vascular Center. I want to welcome you to DeBakey CV Live, and we're coming to you from Houston, which is deep in the heart of Texas. So tonight we're going to take on a controversial topic, and that is the minimally invasive approach to atrial fibrillation. And I'm delighted to be joined by three experts, all experts in their own right, and you'll hear from them later. But to kick this off, I'm going to introduce one of the newest members of our cardiovascular surgery faculty, and that's Dr. Randall Wolf. And Randy joined us with a history of being involved in minimally invasive surgery for AFib for many years, and he adds that to the armamentarium here at the Heart and Vascular Center. So Randy, you're going to educate us a little bit about the basics of atrial fibrillation, because this is not what I do, so I'm going to be asking you questions from the novice standpoint.
That's fine. Alan, thanks for the introduction. It's my pleasure to be here. I want to thank all the people that have helped our relocation to the Methodist Hospital and the AFib Center here. Really, we're going to do three things in the course of probably 45 minutes or so. One is I will give a little background on what the minimally invasive surgical approach is for those of you who may not be familiar with it. The second part is to have some testimonials from two people here that have been through the whole AFib saga, and their story may be very similar to yours, so you don't want to miss them discussing their story with you. The third part is to take your questions. And there are a couple different ways to take your questions. There's phone, which is 713-482-1108. That's 713-482-1108. You can text Methodist to 37607, 37607, and online is pollev.com/Methodist. So if you have a question, you do not have to wait till my little part of the talk is over. If you'd like to queue in and get your question, that's fine with us, because I know I'm going to be interrupted by Alan anyway.
Probably. Guaranteed.
If we could go to the slides, though, I'd like to give you a little background for a few minutes on what is really a passion of mine, and has been now for 18 years, and that is trying to find better ways to treat atrial fibrillation. I first titled the slide this, Wisdom from 18 Years Experience, but then I changed it, because really what people want to know is, can they stop blood thinners, can they eliminate strokes, can they get in rhythm? So that's what really this is about. Now, as a disclosure, I am inventor of some of the products which I will show you, and I continue to work with the engineering crew on developing new products to treat atrial fibrillation. This is really a really good cartoon of what we can do minimally invasively. If there are triggers on the heart, on the back of the heart, in the left atrium, we developed a device, a clamp that surrounds this area, can isolate a spot of AFib in about 10 seconds. The clamp can be placed minimally invasively while the heart's beating, without the heart-lung machine, with no blood thinners, and in 10 seconds it makes a line through the heart. It does not burn a wide area. If you check 1 centimeter outside that line, the temperature is normal. So this is done on the beating heart. Did a fellow yesterday who came here from Dallas with AFib, 46 years old. So this occurs in younger people too. And we can create that line, which not only controls that focus of AFib, but it also interrupts little nerves on the outside of the heart. And in my opinion, and the opinion of some others, a lot of AFib is vagal AFib. It starts because you have an imbalance of the autonomic nervous system. And the beautiful thing about going on the outside of the heart is that's where the nerves are. Now, when we did our first experiments in animals 18 years ago, we were able to tell that this procedure really worked in creating a line through the heart, and these are some films of the first times we used this clamp. It was very effective. I then went to University of Leiden, this was 18 years ago, and started doing some open cases using this clamp in patients who had AFib. They also had valve problems. So for the first time, we could treat the valve problem and the AFib at the same time. That's called concomitant procedure. But I was really interested, could we take care of patients who have lone AFib? That's all they have. They don't need a valve procedure. They don't need coronary bypass. They just have AFib. And we were successful in doing that at the University of Cincinnati back in 2003. This is a picture of one of the first cases, and my mentor looking over my shoulder, Dr. Flagey, who just passed away last year. This started our journey of treating lone AFib in patients.
So can I ask you a question, Randy? So when you say lone AFib, you're really talking about patients who have AFib, no coronary artery disease, no valve disease, and that's the only reason you're going to have to do a procedure on them.
That's correct. That is correct. And if you talk to a lot of these patients, they see their internist or their family practitioner, and many times they're put on some medications and they're told, you just have to live with AFib and take these medications. So the patients don't have hope. It takes their hope away. And what we really want to be happy is, I mean, hope is a lot of happiness, is hope. People want hope, and they want to see if they can get back in rhythm and get off these drugs. So they're really looking for something. Now, a small percentage of the AFib patients will see an electrophysiologist, a specialist in cardiology, but a lot of patients don't.
Any idea what percentage that is that actually get referred to an electrophysiologist?
Well, it's been mentioned to me that only about 5% of people around the world that have AFib see an electrophysiologist. It's pretty small.
Seems like there's a huge education opportunity then.
Yes,
yeah.
Maybe that's why we're here. So this is the procedure that I developed. It was called bilateral pulmonary vein isolation and excision of the left atrial appendage, little ear on the heart. If you are out there in the audience and you're taking a blood thinner for AFib, you're taking that blood thinner to decrease your chance of stroke. But you're taking it to decrease the chance of stroke with a blood clot coming from one place, and that's the left atrial appendage, a little ear on the heart. It's like an appendix on the heart. Well, with this mini maze procedure, we close that appendix, so that eliminates the risk of stroke from that left atrial appendage. And additionally, as I mentioned, we also treat the nerves.
Does anybody, why do we have an appendage? I mean, I never hear anything good about it.
You mean the appendage on the heart?
Yeah, the appendage on the heart, yeah.
Well, as it turns out, when we're developing as an embryo, way before we're born, and the heart develops and the lungs develop, and then the pulmonary veins from the lungs grow into the heart, and that back of the heart moves away so the pulmonary veins can grow in. That back of the heart that moves away is the appendage.
Okay.
And we have two. We have a right atrial appendage and a left.
Did you get clots in the right atrial appendage?
It's unusual. The right atrial appendage has a very wide mouth. It's a low pressure system, and even if you did have a clot in the right atrial appendage and it left the heart, it would go out into the lungs, and our lungs naturally have an enzyme that breaks up small clots. Unfortunately, if the blood clot comes from the left atrial appendage, then it goes, as you so well know, through the aorta, and the first branches off the aorta are the carotid arteries. If it goes into the carotid arteries, it can cause a stroke. And generally, AFib strokes are very devastating strokes. They're big strokes. So this is what the procedure looks like. It's the mini maze procedure that was named by one of my patients who said, Doc, this bilateral pulmonary vein isolation isn't going to cut it, so I gave you a new name, Wolf mini maze, or mini maze. It's done like if any of you have ever had your gallbladder removed or your knee scoped. We use the same type of scopes here at the DeBakey Center at Methodist Hospital. They go between the ribs. We can see the heart. We can operate on the heart. We do not put our hands inside the body. We can operate on the beating heart. This is a picture. It's what it looks like. We can see everything. We can do everything. We have some special instruments, again, because we're not putting our hands inside the body. And just to give you a little flavor of what it looks like, this is the view that we see through the scope. We can see the heart, we can see the pulmonary veins, we can isolate the pulmonary veins. In about 10 seconds, those veins are isolated. There you can see the line around the veins, and that's with the heart beating and with no incision big enough to put a hand inside the chest.
So do you make more than one line, Randy?
I do make more than one line because I like to get up on near the right atrium because that's where a lot of the nerves are. So that second line is not so much to isolate the pulmonary veins, but to interrupt those little autonomic nerves. These are the kind of nerves that makes your hands sweat when you look over the edge of a tall building. They're the nerves that make your heart beat rapidly when you're watching a scary movie. Why should your heart rate go up when you're watching a scary movie? You're not running. These are the autonomic nerves, and this interrupts those nerves. On the other side, you mentioned the left atrial appendage. It's right here, Alan, and this is a clip that we developed that closes the appendage in about a minute. and it completely closes it. We also do this while we're looking on an echocardiogram. And there's the clip. That's the left atrial appendage. Inside the clip, we can see the heart beating. We can see the pulmonary artery in the background. And this is very effective in allowing people to stop blood thinners. In some patients here, we just do this. We don't do the whole procedure because they can't take blood thinners, and they're at risk, and they have AFib.
So one of the criticisms that we've heard is, how do you know you've got that clip?
Yeah.
In exactly the right place.
Yeah. So we
I guess in theory, if you leave, if you've got a cul-de-sac and you clip it here and leave a little cul-de-sac, you're probably not any better off.
Right. Probably worse off. Yeah. Exactly. So we use belt and suspenders. We have the scope in. We can see this. Plus, I've done over 2,000 of them. I know where it goes, but we can see it grossly. But at the same time, our anesthesiologist is looking at the echo, and they can see the appendage open, and then it disappears.
So it's not me who's going to interrupt you this time. We're going to take our caller on the line.
Sure.
You want to pass him on to us, Tyree?
He's ready. You can talk to him. His name is Chris.
Hey, Chris. Hey, this is Alan Lumsden. We're joined here, actually, let me introduce two guests, Catherine and David. We're going to hear from them a little bit, and you've heard both from Randy and I. So, Chris, please go ahead.
Yeah, I've got two questions. And my first question is, do you have to be in AFib when you do the surgery?
You want me to take that?
Yeah, so if you can hang on the line, Chris, if you would. Let's deal with that first of all.
Yeah.
So we got paroxysmal AFib.
Right.
And it's going away.
Yeah.
And I come in to see you. Are you going to cancel the operation?
It doesn't matter. For the mini-maze, it makes no difference whether the heart is in rhythm or out of rhythm before or during the procedure.
Great question. Go ahead, Chris. Your second question?
Okay. And my second question is, what are some of the negative effects that can happen?
Okay, so let me frame that, because I read the studies last night, and one of the trials said there's a higher complication rate from doing surgery versus doing ablation. Do you want to handle that?
Yeah. The main study that was done several years ago, Chris, and it took two groups of people and divided them into surgery and catheter ablation. These are people that already had failed a catheter ablation or had continuous AFib. And at 1 year, they then checked the patients to see what percent were in rhythm. The percent in rhythm in the surgery group was twice as high as the percent in the catheter ablation. So the surgery, the mini-maze, was far superior. There was one death in the whole study, but it wasn't in the surgery group. Interestingly, it was in the catheter ablation group. There were some complications right after surgery that did not affect the outcome of the patient. These are complications that, frankly, I've never seen. So there were two groups of surgeons in two different cities in Europe that did this. I know the surgeons, but they were not very, I would say, seasoned in the procedure. So I think some of the complications that they saw were related to their inexperience doing the procedure. We just frankly don't see these complications. So it's a very low complication rate here at Methodist.
Okay.
Okay, and I actually have one more if I can ask another.
Sure.
You lied to us. You said you only had two.
Three. Go ahead.
So I'm on flecainide, and how long do you have to be off of that before you do the surgery?
Yeah, and these are questions that often come up with catheter ablation. The surgery is different, so it's a good question. The answer is you don't have to be off of it at all, because with the surgery, you don't have to be an AFib to have the procedure. I developed a probe that we put on the heart, and we test the electrical activity on the heart. It doesn't matter if you're in or out of AFib. So we leave patients on their flecainide, on their amiodarone. We do the procedure. We usually put 90% of the patients have a small device put under their skin a week after the procedure, and we can follow your rhythm for the next 3 years without you having to go to a doctor or going to an ER. And if you're staying out of rhythm, we stop your drug. So the answer is you don't have to stop it at all for the mini-maze procedure.
Thank you, Chris. Appreciate it.
Thank y'all.
Let's go have Randy's slides back up and we'll finish off.
Yeah, I'll finish off here. Okay.
Yeah, let me go ahead. That was great that Chris crawled in. We just want to remind you there's 3 ways of asking questions. One is by calling. The number is 713-482-1108. or by text message. You text Methodist, so call 37607, text Methodist, and you'll be allowed to ask a question. Or you can see that online number, you can do it through the internet, polev.com/Methodist.
All right, we'll show a few more slides. Feel free to contact us. This was the first patient that we did the mini maze on. We checked on him 12 years after the procedure, and he was in normal sinus rhythm. His wife said, "I got my husband back." And I think this is something that's very helpful. About half the patients who have AFib are incapacitated by their AFib. And Catherine, I think that was your situation, right?
Absolutely.
And David, your situation, you weren't incapacitated by it.
No.
So this is perfect. About 50% aren't, 50% of the patients aren't. A lot of the patients tell us the main thing that they really love is getting off blood thinners.
Yes.
So that's one of the advantages of the mini maze procedure. We also take care of a lot of patients who've had previous catheter ablation, and for whatever reason they still have AFib. A common question is, can you still have the surgical procedure if you've failed 3 catheter ablations? And the answer is yes. And in fact, it's a very high rate of being in sinus rhythm 1 year after failed catheter ablations if you've had the mini maze. After the mini maze, it's 92% AFib free rate after a failed ablation than a mini maze. So it's very high. There was a presentation recently in New York from another group. They got the same number. 92% of patients who had the mini maze after failed ablation were in rhythm after 1 year. We do some electrical testing during the procedure.
So let me just show you how you do
where to
that.
go.
Again, just so that we're all on the same page. Can you go back that slide?
Maybe.
Is that maybe technology fails us going backwards? No, but basically what you're doing is you're putting a probe, an electrode on the heart,
Yep.
stimulating it with an electric current and sensing it on the other side of your ablation line,
Yes.
and see whether or not it conducts. And
Yes,
the
sir.
whole concept is that it should not conduct. Now, I'm sure half our audience doesn't know what RSPV and LSPV is.
No. And it doesn't matter that much.
That's right superior pulmonary vein and the left inferior pulmonary vein, I think it was. So again, we're going to interrupt you one more time. We have another caller on the line. So caller, I think it's Tom. Tom, go ahead with your question, please.
Sure. Dr. Wolfe.
Dr. Wolfe.
Yeah.
In America, Indianapolis.
Go ahead. We can hear you.
Yeah, this is Tom Heck, Indianapolis. Dr. Wolfe.
Oh, Tom Heck. Oh goodness, I recognize the name and the voice. Tom, how are you?
Doing great. Had it done in 2011. Still fishing, still building things. Still
Tom-
doing the honeydew.
Tom, I remember you so well. Your wife is a nurse. We started a program at the Indianapolis Heart Hospital where your wife worked. And I think you told me you'd been to the emergency room something like 50 times with AFib. And you told me you'd get in your truck after work and you'd fall asleep in the parking lot because you were too tired to drive home. And you ultimately had the mini maze at the heart hospital there. And after that, you were able to get back and do the things you like to do. You also told me your wife would set out things for you to do on the weekend and put the shovel out to get out in the yard. And on Sunday nights, you'd put them all away and you were on the couch the whole weekend until you got back in rhythm.
All right.
Yeah, that's the view.
Do you have a question, Tom?
Okay, you have a good.
All right. Thank you. Thanks very much for calling in. We appreciate it. So if people can do anything they want, you know. People say to me, the guys say, what can I do after you fix the aneurysm? Well, you can do anything. You can't walk the dog, you can't cut the grass, you can't do the dishes, and you must have the remote control in your right hand the entire time. But I said, that's extra. We charge extra for that operation. Anyway, sorry, go ahead.
Well, I was just going to say that this is a patient that had some failed ablations. We make our lines with the clamp, and then we test again. And this is kind of technical, but that second line there is flat, and that shows there's no
So what it
electricity
says
going through there.
EKG2.
Yeah.
Is that a flat line or is that a line on the curve?
The top line is your surface ECG. That second line means there's no more electricity
that little,
going through those
the little
veins.
squiggly line. Okay.
So that's how we test, that's how we document what we've done. Again, I want to emphasize, we believe that taking care of the left atrial appendage is of paramount importance for several reasons. One, it decreases the chance of stroke if it's closed. Two, you can stop blood thinners. Three, it can be a focus of the AFib, so it can also be an area where the AFib is happening. By closing it, you make it electrically silent. The Watchman device, somebody may ask
so
about
it does,
that.
when you put that clip on, it's the equivalent of putting in an ablation line, is what you're
Right,
saying.
it's
Okay.
equivalent of cutting it off.
Yeah, oh,
Yeah.
you cut it off, that's
No,
right.
I
After
don't.
you-
No, I don't.
you
But it's
Okay.
equivalent to.
Okay, that's
Yeah.
interesting. I didn't realize that. Okay, we have another caller on the line.
Gary.
Hey, Gary, welcome to CV Live. You have a question for Dr. Wolfe?
Yes, sir. I've had an ablation. I've also did stem cell therapy a year after that. The first ablation did not work per se. I had 2 inversions. But when I started taking Pedialyte, then my heart went back to rhythm. And it stayed that way for almost a year. Then I've been out of rhythm for quite a while. The stem cell therapy didn't work at all. And then I tried alkaline 88 water, and that seems to be taking me in and out. I'm right now looking to go get another ablation, and I have an appointment next month. But this procedure here is pretty interesting for me. And the start of my problem was a car accident, and the other part was I have a family history
Yeah. Well,
of heart problems.
so in summary, you have AFib, a family history of AFib. You had an ablation. It worked for a while, but now it's not working. Do you think you're out of rhythm all the time?
No, sir.
So you have paroxysmal AFib. So you have a choice to make. You either take medications, you go for a second catheter ablation, or you try the mini maze. I think those are all 3 options for you. You're doing the right thing. You do your homework. You decide what's best for you. But this would certainly be an option for you.
The question I have is, like I said, the catheter ablation would not work until I took the Pedialyte, and that allowed the electrical signals to flow through to the heart chambers properly.
Yeah.
But then it quit.
Yeah, well, the
Interesting.
nature of the disease is the medications stop working, and the AFib comes back more often and lasts for a longer period of time. But you would be a candidate for the mini maze.
Okay, did the mini maze actually put me back into sinus rhythm?
Yes, sir. If you're in rhythm, then at 1 year you got 92 chances out of 100 of being in rhythm without medications. Excuse me, that's after the mini maze.
Okay.
Not 100%. Not 100%, but it's pretty darn good. Thanks
What's
for.
the recovery time?
Well, we ask people to come to Houston for about 10 days. It's about 3 days in the hospital, and when you're 7 days out, excuse me, then we see you in the office and let you fly home.
So we have another question.
And this is in Houston?
Yeah, and we're at Houston at Methodist Hospital, DeBakey Heart and Vascular Center.
Okay.
Thanks for
Well, I
calling.
appreciate
It's a
your
good
time.
call.
I'll have to think about it.
877-900-2342 if you want to call for the AFib coordinator. 877-900.
Again, sir? I missed that.
877-900-2342.
So thank you very much for calling in. I think we have another question by text message. Okay, question for
thank
Dr.
you.
Wolfe.
Bye-bye.
I'm really nervous about doing a surgical procedure. Help me understand why your procedure is better than a non-surgical procedure. I think you hear this all the time. This is kind of my world, is that I do both catheter-based interventions and open procedures. And those are called endovascular procedures. And there's a very interesting publication recently. It was called Endoexuberance. We all want to do the most minimally invasive procedure, but we also want to do one that's efficacious at the end of the day. And so how do you respond to that? I can come in and get a catheter ablation through the groin.
Yeah.
Now, there's some risk associated with that versus you're going to open my chest.
Well, I think saying you're going to open my chest is a misnomer because the largest incision is 6 centimeters, which is about like that, and the other two are 1 centimeter. These patients are awake, like the patient from yesterday is awake here at Methodist in the OR after the procedure. This morning he's sitting up in a chair having a normal breakfast. So this is truly minimally invasive surgery. What's the difference between a mini maze and catheter ablation? Well, one is the AFib free rate after the mini maze is about twice as good as catheter ablation. The other difference is with a catheter ablation, a lot of burns have to be placed on the back of the heart. It's not so easy to do. I mean, EPs, electrophysiologists, do not have an easy job. Oh, it's not an easy procedure. And a lot of burns have to be made, and they have to form a line. With the mini maze, there's just a line, so there's very little damage to the heart. So I say to people with the mini maze, there's more incisions on the outside of the body, but as far as on the heart itself, it's less. No. The other question?
What's the difference between a hybrid maze and a mini maze?
There are lots of different hybrid mazes. We do that too.
I mean, in broad terms, it's a hybrid between what you're doing and the catheter ablation.
Exactly. Yeah. That's right. That's right. It's a combination. Generally, our patients have the mini maze. If 1 year later they're still out of rhythm, we will add a catheter ablation to find other spots. Another type of hybrid procedure is going in below the xiphoid process, burning just the back of the heart by the surgeon, and the rest is done by the EP. Both those are called hybrid procedures.
Okay. Very good. Have you finished your presentation, Randy?
Well, you know, I'd really like to get Catherine and David to talk. I'd like to give them some talk because I think they have some.
Me too.
They may answer some people's questions.
So let us ask. This is one more question. I have AFib, but I've not had any surgery. Can I do mini maze rather than ablation? Completely virgin chest, you know. He's salivating.
No, that was
I think Catherine can answer that question.
Catherine. So why don't you introduce Catherine?
Absolutely. I had no catheter ablation. I was on flecainide and metoprolol. And I came in for my mini maze, never having had a catheter ablation.
But tell us, first of all, why are you down here? You live in Chicago. What on earth are you doing down here in Houston to do this?
Well, I have a history with Dr. Wolfe. My father battled AFib for a decade, and he had 3 failed catheter ablations and was on amiodarone, and that had failed him, and we found Dr. Wolfe. And he did my father's surgery 6 years ago last month, and though I had no idea at the time, 4 years later, I was sitting in my kitchen and suddenly had an onset of AFib.
How did you know you had AFib?
Well, my dad had been symptomatic so often for a dozen years.
What were your symptoms?
Accelerated heart rate.
So you could feel your heart pounding.
It was over 200 beats per minute.
Oh yeah.
So that gets your attention.
So normal heartbeat's 80.
Right.
200, not good.
I did more than the doubler on that,
yep.
and I actually had a blood pressure cuff, put that on, and my pressure was high, my heart rate was high. Which were the symptoms that my father had had. So I went to the ER and was confirmed that I was not in sinus rhythm. And that kept happening despite medications and increasing the rates of medication. And so I opted to contact Dr. Wolfe right away.
Why? Why are you different from 90% of the population who go and get ablations first of all?
I think because I saw what my father went through. My father, at the point we found Dr. Wolfe, was distraught. I mean, he was despondent because he was at a point where he could rarely leave the house, could barely walk because of AFib being so serious. He'd had 3 catheter ablations. None had worked for more than 12 months.
He was told there was nothing else that could be done.
He was told there was nothing else that could be done. Right. We had sought out experts beyond our hometown, and so I saw that, and he was older than me, obviously. I mean, I was in my mid-50s when this hit, and I did not want that to be my next dozen years. So.
What did your dad do after he had the mini maze?
Well, he's going to be 84 this year, and they have moved to Florida. He's in silver sneakers. He works out regularly. He does whatever he wants.
That's right. But in fairness to the EP guys, who also work here in the Heart and Vascular Center, some people do remain in sinus. There are a few people, who, of course, who break through and do need repeated intervention. But, you know, their argument is that 80-90% of people after 2 ablations, paraphrasing a little bit in terms of these numbers, so don't quote me, it does work in some patients. And one of the things I've learned is you got to have options. There is no one magic bullet for all patients, and so you got to have these options. So
I was just saying, I think for me, I ended up in 8 weeks, I was in the hospital 6 times with increasing medication. So I think I had an unusually
aggressive.
50% of the patients with AFib, like Catherine, are incapacitated when they have an episode.
And how did it incapacitate? What was it?
I mean, with the heart rate so high, and I was exhausted to try and cross the room. And I'm somebody who plays tennis, I jog, I bike, I do all sorts of things, but that was all taken from me. I could do basically nothing.
She's very modest. The tennis season is half over. She's a singles player, and she's undefeated this season.
Very good. So I think we have one other question, and then we're going to take a little break. What is the relationship between the older you are and having this procedure done until you're back in rhythm? So does age play a role? Number one, does age play a role in it?
Age does not play a role, Alan. The youngest patient that I performed the mini-maze on was 15 years old.
Those are
and I've taken care of several students, medical students who've had AFib. The oldest is 90. We did a 90-year-old from Victoria not too long ago. She was back home 3 days later.
So I think the second part of the essence of that question is the outcome different if you're older?
No, the outcome is not different if you're older. There are 2 things that determine the outcome. There are really 3, but 2 important things. One is how big is the left atrium by echocardiogram before the procedure is done. If it's greater than 5 centimeters, then the chances of staying in rhythm start to go down. And secondly, how long has the heart been continuously out of rhythm? Now, if it's been paroxysmal, in and out for 20 years, doesn't matter. But how long has it been continuously out? And if it's more than a couple years, then the chances start to go down a little bit. And if it's been more than 5 years, then it goes down more. But some of those patients say, well, at least close my appendage and get me off the blood thinners.
Right. Okay, so we're at the 30-minute mark. Let's just go ahead and take a quick break, and then we'll get David on board and the story. Thank you.
Sure.
Hello, my name is Ross Rule, cardiovascular and thoracic surgeon at Houston Methodist Hospital. Greetings from the Texas Medical Center. On behalf of the DeBakey Heart and Vascular Center, I welcome you to join us for the Cardiovascular Fellows Bootcamp. This will take place at the Houston Methodist Research Institute and the Hotel Zaza just down the street. This is a truly unique opportunity for first-year cardiac surgery fellows to have a crash course in cardiovascular medicine, cardiovascular and endovascular procedures, and invasive diagnostic and therapeutic technologies. This course has been described as Disney World for cardiovascular surgeons without all the lines. It is truly multidisciplinary, hands-on experience complemented by lectures, simulations, and a direct instruction from the basics to the newest innovations. This is an excellent introduction to transition fellows into the world of cardiovascular surgery, guided by world-class faculty. The full schedule of lectures, hands-on sessions, and events can be found on our website, along with complimentary registration, travel, and lodging. We are offering a stipend on a first-come, first-served basis for qualified attendees. We hope you'll join us, and we look forward to seeing you at Bootcamp in August in Houston.
Well, welcome back. I'm back to DeBakey CV Live. Let me put Randy on the spot. Please introduce David. He's somebody you've known for a long time.
David Garber is from Houston, and he's a pilot, commercial pilot, and unfortunately developed atrial fibrillation, and they picked it up on a flight physical, which must have been a pretty depressing day for you. And with that introduction, I'll hand it over to you.
It really was. Basically, an airline or any pilot has 2 parts to his license. One is the actual license itself, but the second part is medical. And you have to have both in order to fly. So that would put me on the ground And one of the things that I love to do is fly. So
You
it
look a little bit like Sully Sullenberg.
Yeah.
I'm sorry, I shouldn't interrupt
well, so at any rate, you know, when I got into I was in proximal, sysmal, which means intermittent, and then it went to continuous. And the one thing, you know, I went to your seminar, and when I was there, one of the things that impressed me was getting rid of the LAA, because, you know, I knew that I was going to have to be on blood thinners if I didn't. And I had not yet tried the carotid system, and like you did. So my first choice was the mini-Mayas, because
So you did not go with the ablation?
no,
first?
I did not.
Usually with the ablation, the appendage is not treated.
Yeah.
And that was probably a downside for you.
Well, my brother had had a stroke previously, and I saw what he went through, and his wasn't from that, but
Yeah.
it was scary to me. And I did not want to, one, I didn't want to have a stroke, and two, I did not want to be on blood thinners.
How long ago did you have your mini-Maze procedure?
That was December of 17.
And are you flying again?
I am. I am.
Right.
It took a little bit of time from December until, I want to say, April or May before it finally calmed down.
Yeah, but you were in continuous AFib. That's not too unusual. Yeah, takes a little more time.
But one of the things that you did was to put in the Medtronics link,
Yeah.
which is a fascinating piece of technology, because it monitors my heart, and it also, there's a little box next to my bed, and that sends all the information to your office, so that he is continuing to monitor my heart and see if there's any AFib. And so I was able to watch it decrease. So
Cindy Rosenbaum, who's the AFib coordinator, is following probably 200 patients now here at Methodist who have what you have, the link device, a monitor, and you don't have to do anything, right?
No.
It takes care of it.
No.
And it's inserted through an incision probably this
Right,
size.
yes, right
It's
here,
more
it's
like a
very
needle
small.
that you
Yeah.
pop this in.
It's essentially a modified syringe to put
Yeah.
under the skin, yeah, that's right.
So,
But
so
it's-
Randy, can I ask you one question? So when a patient goes back into rhythm, is it they have a burst, goes in rhythm, a shorter burst in rhythm, a shorter, or do they just convert and back into sinus rhythm?
Most patients, a lot of patients convert in the operating room if they've been in continuous AFib. If they've been in paroxysmal AFib, oftentimes what we'll see is their AFib burden will decrease dramatically, because what David talked about, this link device, it also gives us every month the AFib burden. Is it 5%, 50%? A lot of patients start out with 100%, then we see it's 5%, and a month later it's 2%. So they still have some episodes,
Oh.
but they become very short and then they disappear.
Okay, very good. Sorry, I interrupted you.
no.
You were going to say something? Yeah.
Well, it was, you know, I was able to eventually get back with we have doctors who give these physicals for the FAA, and so we were able to work with my other cardiologist and provide information to the medical team in Oklahoma City at the FAA, and I was eventually able to get my medical back, and I've had it. I continually have to give them some information once a year, but it's, as long as I stay in sinus rhythm, I'm good to go as far as they're concerned.
It's fascinating. Someone I used to know very well was an aviation medical examiner, and she said, "These guys are the coolest of the cool, except when they're coming in to get their." I said, "It's life changing. I mean, it's like you walk into that office and then you get told you get AFib, and you know this is definitely over." Anyway, I think we got another caller on the line. Don't want to keep him holding.
Colonel Chuck.
Okay, caller, go ahead. Go ahead. We hear you.
Well, there's a question on the screen there.
No, it's on Colonel Chuck.
All right, let's take one of the questions on the screen while we reconnect if possible. Guess we'll go from the bottom up. Do you deflate the lungs to do this procedure?
Well, what we do is we ventilate one lung over the other, so we don't stick a needle in the lung and let the air out. But what we do, in order to see the heart, the lung has to be out of the way on that side. So we specifically ventilate one side and then the other.
So you put a breathing tube in that you can control each lung independently.
Correct.
And so you collapse the lung on the side you're going to work on. Because when I was reading that paper, one of the complications that was reported was incomplete reinflation of the lung. And that was reported as, I mean, that's almost normal.
Yeah.
A little bit, yeah. Okay. All right, second question is, if you have a pacemaker, can you have this procedure done?
If you have a pacemaker, yes, you can have this procedure done. Which camera are we on now? Over here. Yes, you can have this procedure done. In fact, the patient we operated on yesterday, the 46-year-old, has both a pacemaker and an AICD.
An AICD is what?
Oh, yes.
Jargon. I gotta keep them honest in the medical
It's a
jargon.
defibrillator, so it will also shock the heart back into rhythm. But the answer is yes, it makes no difference at all.
Okay. Thank you. Okay, caller. Is it Chuck?
Yes.
Go ahead. We hear you.
Yes, this is Colonel.
Yeah, you're coming and going a little bit, but let's see if we can hear you. Do you have a question?
Yes, I'm a long first patient, Dr. Wolfe. I suffered cold AFib 15 years, retiring as a pilot. And I was his 37th.
Wow.
And
You're fading in and out a little bit, Chuck, but we're kind of getting the gist of it. Another.
You have a loyal following, my friend.
Air Force colonel.
Okay.
Flew the refueling plane.
Oh.
And just published a book within the last year that was #1 online for a while.
Is that right?
That's great.
That seems like an incredibly hazardous job.
Are you still on, Chuck?
No.
Okay. Thank you for calling. Sorry, we had trouble hearing you.
Yeah.
Okay, another question. Question for Catherine and David. How did you hear about Dr. Wolfe?
Well, originally, when my father was having such great trouble with AFib, we actually found out it was just like this. It was an informational seminar that Dr. Wolfe was giving, and we saw actually a notice about it that was printed
In Indianapolis.
and went to it, and thereafter my father made an appointment and got in, was scheduled, and then so I already actually knew about Dr. Wolfe, and my father had kept in touch, so he also is a huge fan of Dr. Wolfe, and so I knew that he was here in Houston, and so I traveled from Indiana for my surgery and was here in Houston for
And so
4
you
days.
flew down from Chicago.
I did.
Today. So
I flew down today
yeah.
to be here with him.
Why? Is that great?
Because
Is that great a guy?
He is
Yeah.
absolutely, he's that great of a guy.
But it's interesting because through Dr. Wolfe and getting more involved in AFib, there are a lot of evangelists out there who are really interested in AFib. And I was last night on that stopafib.org website. That's an amazing website.
It is.
And the lady who put that thing together seems to be,
Yes.
she must spend her entire life. What's her name? Melanie
True
True Hills, yeah.
True Hill.
Really
And we should give her a plug because I will be
Sure.
speaking at her conference, Alan, in August.
Yeah, I want to do it. So it's August 9th, I think, up in Dallas, but they got the
Yes.
best tagline ever. Get in rhythm, stay in rhythm. Yeah.
Yeah,
You
that's,
can't- you
that's
can't
where,
beat it.
where I first heard about Dr.
Oh, you did?
Wolfe. Yes. I went to the conference
In Dallas.
in Dallas.
Okay, there we go.
And
So this is a
then I found out you were in my neighborhood.
That's usually what happens. So this is a conference in Dallas on August 9th. It's on the stopafib.org website. And yeah, I tell you, the content on there was pretty good. Oh, actually, in fact, it was
It's
excellent.
2.5 days of
Yeah.
nothing but AFib.
And
Yeah.
it's patient focused.
Totally.
It is.
All right, so we have another caller on the line. Caller's name is? Michaela, you have a question?
Yes, no, actually, Sam, no. I'm here really as a former patient of Dr. Wolfe, and to attest of how lucky I was in life to have intersected with Dr. Wolfe. I'm a former AFib patient, and I bumped into Dr. Wolfe at a atrial fibrillation seminar in Dallas. And like most AFib people, I had no clue about where to go and what options were available for me. But that seminar, I met Dr. Wolfe. We coordinated a surgical mini-maze ablation. And as a result, I have been AFib free for almost 3 years. And it's been a perfectly delightful time of my life. And I wanted to call in to personally thank Dr. Wolfe for his skillful treatment and his personable treatment of all of his patients. And I am not necessarily what one would consider the kind of person who would normally do these kinds of endorsements and testimonials. And as a follow-up to that, there are roughly 5 other AFib patients I know, 2 of whom who had persistent, continual AFib that have gone through Dr. Wolfe's procedure, and all 6 of us are living better lives because we had the pleasure of meeting Dr. Wolfe. So, Randy, thank you very much for what you have done for all of us and for advancing the lives of a lot of atrial fibrillation patients.
Well, thank you, Michaela. And you don't live close by either, do you? Tell everybody where you live. I think she went offline, but she lives in Connecticut.
Hello?
Yeah, we hear you. Yeah. Well,
Thank you very much.
That's another great couple of words, skillful and personable.
Hey,
That's a.
I'll echo that.
That's
too.
very good. That's very,
I think
very
this
good.
is
Yeah.
becoming the Randy fan club.
I know, it's like,
Well, you know, this is an interesting thing that I figured out. You know, if you have appendicitis, you go to the emergency room and the surgeon comes in, you go have it taken care of. AFib's different. It's a chronic disease, and you deal with this too. So people do their homework, and they get online and they say, what can I do? How can I get some hope? How can I get back in rhythm? How can I get off blood thinners? So people will spend a lot of time. So it's a chronic disease.
Yep.
It's a different mindset.
It really is.
so one of the things you mentioned though was, I'm trying to keep you honest here, Randy, but taking the appendix out. Now the EP guy's going to say, that used to be the case, but now I've got Watchman, and I can
Right.
put a Watchman in the appendix.
Right. You know, 15 years ago when I started removing the appendages, I went to the EPs and said, I can get these patients off blood thinners, let me remove the appendage. They go, really don't need it. We don't need it. I said, you will once you figure out a way you can do it. And they have figured out a way, and it's an interesting technology. The Watchman device has a couple drawbacks. One, it doesn't electrically isolate the appendage, so that appendage can still serve as a site for AFib. That's number one. Number two, almost all the Watchman devices leak. Number three is, if you look at its efficacy, it does not decrease the thrombotic AFib strokes. They're the same as Coumadin. What it does decrease is hemorrhagic strokes, bleeding strokes, but that's because you stop the blood thinner. So its efficacy, I think, is somewhat questionable.
Okay. All right. Any other questions, comments?
Yeah. What would, anything you'd like to tell all the people that are watching this? Because you both have been through it, done your homework.
I would say strongly consider the Wolfe Mini Maze. I tell people I have 2 birthdays. I have the date I was born, and I have July 10th, 2017, when I came to Houston and had my Wolfe Mini Maze. I mean, it was that transformative for me. And my medication was not working. I'd spent so much time in hospitals and was totally sidelined. And that's all gone.
So I think that goes back to what we were talking about before, is hope.
Exactly.
And your hope with the symptomatic portion of AFib, I can identify with, although I did not experience the same thing.
So what do you mean by that? So you were having AFib that was completely undiagnosed until you went to that doctor's office, and then your life was changed.
Right.
And how do they let you continue to fly?
Well, it didn't at that point. That we paused my flying career until I wound up with Dr. Wolfe.
But I think it kind of emphasizes the spectrum of this disease, is that some people are completely incapacitated physiologically immediately. Other people don't even know that they've got it.
Right. I was asymptomatic.
Although, wouldn't you agree, David, that one of the things that really was horrifying was that risk of stroke? I mean, I know each time I went into the hospital, I'm thinking, oh, it's, you know, my left atrial appendage is filling with pooled blood, and there I've reset the clock on perhaps having some sort of a stroke event that, I don't know, I just, that was very stressful in addition to the stress of everything else. So
But I think that was the thing that,
that's the tipping point.
the tipping point.
It's a time bomb. You don't know when it's going to go
Right.
off. That worries you a lot. And I think when people think about this, AFib is not just a heart problem. It's a brain problem too. And the most devastating thing that can happen with AFib is a stroke, not only for you, but also for your family, but also for society. How much does a stroke cost?
So it's, you know, there's huge interest at the moment in treating stroke. You're in the prevention business, but treating stroke is now a big deal. And it is the single most cost-effective intervention in medicine, because the cost of having somebody who's hemiplegic, it doesn't kill you, it just kind of destroys your functionality, and the cost to society is enormous in terms of doing this. So one of the reservations people have about surgery, we have this pejorative name, we're called surgeons, okay, which means you cut you open. Just tell us a little bit about the hospital experience. How bad was it?
Well, it wasn't that bad. I mean, I woke, woke up after surgery, and then they took me to the thing. I think the hardest time was they were trying to get me to pee.
You know how common that problem is? Remarkably common problem, yeah.
I would echo that. I actually, the hospital experience was wonderful. I mean, the next day I was up, you know, walking laps around the hospital wing, and my surgery was on a Monday. I flew back home on Thursday and actually drove myself home once I got to the airport. So that's, you know, 3 days.
Very naughty.
Three days.
Probably weren't supposed to be doing that.
But I came back.
But she's an attorney.
Well, I signed a waiver. No.
Yeah, that's right. Yeah.
But and then I came back 2 weeks later to have the link implant done and have my checkup. So, but by that point, I felt better. Post-surgery, 2 weeks, I felt better than I had felt in weeks. So.
There are a couple reasons for that.
Okay. Yeah.
One is you're back in rhythm. 2 is you have this hope that you're not going to be with this time bomb again. So it's a mental thing. And the third thing is people that have AFib take a lot of medications. And some people come back and say, I feel better than I have in 10 years. And I go, why would that be? Well, they're off the beta blockers.
Right.
Some people take beta blockers, and by lunchtime, they're finished. They're on the couch. And they say, I have more energy than I ever. I think your dad was that way.
He was.
You get them off the Sodalol, off the beta blockers, they feel better.
Yeah, it's interesting. I had that recent personal experience. My brother from Scotland called me and said, he's got hypertension. He said, there's something wrong with me. I can't function. I feel exhausted. And it's the beta blockers. He stopped the beta blockers, and he said, I'm back to normal. And so you're right. I mean, there are some. Most people can tolerate them.
As surgeons, we'll take credit.
Yeah, all the time to take credit. Okay, but I want to nail you down on the procedure. You get put to sleep. You get a couple of ones, and you reposition the patient intraoperatively, so you do one side, then do the other side. You put on the chest tube?
Yes, chest tube on each side through the port where the scope was.
Okay, so you use one of those.
Than the port, so that comes out the next morning. It slides out through that port. Most people don't even know when it comes out.
Okay.
But yes, there is a chest tube.
And then they're up and about?
Yes, post-operative day one,
okay.
They're up and about.
And you plan to send somebody home?
The fellow we did yesterday here at Methodist probably go out tomorrow or the next day.
And, you know, some people put blocks in the intercostal nerves around where you use that?
Yes, I do. I do block.
So that's basically local anesthetic. If you take the ribs, the nerves run below the ribs, you can put local anesthetic in and block that space. Makes a big difference, obviously.
And we use one that lasts for 3 days.
Good.
Yes.
And then when you go home, what kind of pain pills are you having to take?
Over half of our patients...
You're not taking them. Gabby's taking them. You're not taking them. I hope you're not taking them.
It was fairly mild. I don't actually remember even what it was, and it wasn't for long. Maybe 3 or 4 days. Not long at all.
Yeah, I think maybe a day.
Yeah. I have to say, though, you know, you're talking about surgery and what transformation it does. I think my father who is going to be 84 this fall, had the best line ever, and somebody should probably get a trademark on this. When he woke up and was in recovery, and I think maybe you were even in the room, he looked at me and said, today is the tomorrow we were hoping for yesterday. And that's really true, I think, for AFib. It's that hope that you keep hoping it'll change.
Yeah.
And it does. It does.
That's a good one.
Yeah.
I think about right now, over half the patients that leave Methodist Hospital after mini-maze are not taking any narcotic at all.
Yeah.
Okay, so we got 5 minutes remaining. What do you want to say in wrap up?
Well, with chronic diseases, it's very important to do your homework. And you should look at the mini-maze, you should look at medication, you should look at catheter ablation. And you have to decide yourself what's best for you. And like David, it was very important to be off blood thinners and decrease the stroke rate. So that kind of led you more towards the mini-maze. It may be that you only want one procedure. Well, in that case, I think you'd be more likely to go to the mini-maze. But I think you get the best impression if you see different specialists. And I always say the only doctor that you should be worried about is the one that doesn't want you to get a second opinion.
That's true.
I encourage people to see the EP and the surgeon.
Yeah. So one question was redo chest. Patients had a thoracotomy before, had part of the lung removed. Can you do this?
Yes, that's what we did yesterday. He'd already
the reason
had
that's important is that you get scarring, the lung gets stuck. It's just a lot more dissection in order to be able to do this. Yeah.
We have one of the only series in the world of doing the mini-maze in patients who've had prior chest surgery. Yeah. So most of the time that's a contraindication to surgery. It is not here at Methodist.
Okay. Catherine, any final comments before we sign off? And thank you for coming, by the way. We really appreciate it.
Thank you, and thank you to Dr. Wolfe for inviting me. For me, it was the right choice, and I think Dr. Wolfe is right that everybody has to do their own research. I think, unfortunately for me, I had plenty of time because I was sidelined, but I'm very happy, and I'm now 2 years almost post, and back to doing everything I want. So,
I'd make one other comment that you went to Oklahoma City and you talked to the FAA people up there, the medical people up there. So they know what this is and they know how it works. And that gave me a lot of confidence to know that the people I was relying on to give me my medical back had an expert talking to them.
That's great.
Well, that's true. And I want to thank you, Alan, for broaching this subject. It's a very good one to talk about.
Obviously there's a lot of public interest in it.
Yeah.
So let me thank everybody who's participating here, and let me just say that obviously we focused a little bit on the minimally invasive surgical approaches. I would add that we have a very talented group of electrophysiologists here, some of them doing really cutting edge research such as vein of Marshall, infusion of alcohol, really trying to drill down onto some of the basic science of this. But I've been around long enough to know that I don't have the solution for everything, and you really want to talk to a variety of different people. And I can't echo enough that what Randy said is the only person you need to avoid is the one who's afraid of the second opinion. A second opinion, I'm more than happy to encourage people to go ahead and do that and listen to what other people are thinking. So again, from the Houston Methodist DeBakey Heart and Vascular Center, thank you very, very much indeed for coming. I want to do say, which I think is what you're going to remind me, this will be posted up on our YouTube channel tomorrow. If you look at, the abbreviation is DICET. It stands for DeBakey Institute for Cardiovascular Education and Training. This will be edited and then posted up there tomorrow for anyone who didn't get the opportunity to hear these wonderful people talking about their professional and personal experience. Thank you very much.